there are a lot of things which we are copying from the West, a lot of things which we need from the West, and which can't be applicable to us. So we need to innovate things to us. And my first thought of an innovation came 15 or 17 years ago when I came over to Bharat's place in Stavia to see something, and everything was innovated. So right from the thought process, the Jackson's table to the there's no arm at that time, if I remember right. So in a land of diversity, so on one side you have our Mumbai friends, Ajay, Nene and team. On the other side you have Zubair Javeri and myself on a cycle. So that's how different our country is. And we have to do lot many jugads to get these things done. So we are a land of contrast. So everything needs to be done in a very manifold ways to get this done. So why do we need to modify? First thing, increasing cost of equipment and implants. Not everybody can afford the Medtronics, the Globus, and the etc. Non-availability of these for everyone. They are available in the metros, and the local players are not there. And a lot of times you find that they can't be used by everybody in every small center you see. And of course now, with the Prime Minister from here made in India, makes it all the more to innovate in India. So these are other problems we have. I'm not going into the cases. Just tell you, these are things which our Caucasian friends won't see. Some things which we see here. And I think all of us have to innovate to manage this better. Sometimes our own friends in India practice surgical terrorism. So they do these kind of things. And we have to modify them with innovative techniques. So that's how innovation has to be done. So the pressures of delivering the correct treatment to the unaffording patient at minimum cost, but with maximum benefit and safety, needs innovation. So what are the areas of concern? I'm just briefly going to touch on this and then we'll take it across. So OT setup, OT tables, positioning the patient, specialized retractors, instruments, implants, reduction of radiation, metallurgy, fusion surgeries, non-fusion, etc. So this is courtesy Bharat. I don't know whether Bharat will remember this table from 17 years ago or 15 years ago. So this is a makeshift of the Jackson table, which we have cost. The Jackson table costs about $70,000-$80,000. Of course, our own modification costs only $7,000 to $8,000, and sometimes even cheaper if you nowadays. So this is a straight table where you can have the entire thing going on, where like the Jackson table, you have an attachment here, which goes, the entire thing can be moving in. So that's a modification for us. Now, knee chest position. So we decided that we'll have a better knee chest position, and what we did is we just put the namaz position, incorporated. This can go into any table you want. And this innovation basically makes it feasible for us to work in any peripheral center or any center you want to operate. You don't need a special Jackson table or a McVay or any of these big tables. Now, retraction becomes a major issue when you're doing minimally invasive or when you do mini open surgeries. And these are Homan retractors which we devised. This one which I devised about 15, 16 years back, gave it for Jayan to make. This contains the suction tip as well as it also contains a light source. We attached onto it. So this can be used for any minimally invasive surgery, and it's exactly like the modern jigs you got there. Similarly, you have the speculum retractors. And of course, we also modified the implants to suit our constraints in terms of the instance extenders. We had these towers made across to our benefits. These have become cheaper for us to use now, and these have become standard practice. These were introduced about 10, 11 years ago by us. So same thing when you apply for an MIS TLIF. What we've done, the same retractors in position, and these play a major role for any normal orthopedic spine surgeon or neurosurgeon to do this in any small center, not necessarily in Stavia or Apollo or in Ramchandra. So these again, cases we get, these cases determine what we do, and therefore we need to innovate maximally. So I'm just going briefly into it. So can we adopt this for doing anterior surgery? Yes, we have adopted that. That's when we talk about a single Homan being used. So in this case, for this case, a 5 centimeter incision to this, we done just like you do an OLIF. We have done the same thing, putting one single Homan retractor at the back onto the pedicular area or rubber tip it into the neural foramen, and you can do a corpectomy in a cage as well as anterior instrumentation comfortably for all procedures. And this can be extended for all anteriors. So we don't need big jigs. We don't need big retractors, which are expensive, costing 10, 15 lakhs. So these are advances we need to be looking at. So thoughtful process, so minimally invasive, endoscopic, motion preserving, all these areas are what we have to go on forward. And MISSAB produces the ideal thought process for all the youngsters to look at this. You take it further in terms of working on stainless steel, alloys, nitinol, all these things. And motion preserving is also a major area to consider. So climb mountains not so the world can see you, but so you can see the world.